Welcome to Last Principles, man.
Okay.
Hi there, it's JT here. Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked the tough questions you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and reason your way out of trouble. Now, this is our first official recording in 2024, and we've got some great new hosts who are final year medical students. They're great friends. It's an amazing episode for their first time, and we're really excited to share with you all. So please enjoy. Oh, one last thing. In this episode, we wanted to shout out to our listeners in the United Kingdom, in England, Scotland, Wales, and Northern Ireland. There's probably one of you in Northern Ireland. So thank you very much for listening. Please enjoy, guys.
All right, hi everybody. Thanks for joining in with us today for our first official episode of 2024. My name's Maria and I'll be our presenter for today. I also have a couple other lovely people here in the room. So some guests. Joe, do you want to say hi to our listeners?
Hello, everyone.
Thanks. And Jason, do you want to say hi as well?
Yeah, hey guys.
And in addition to Jason, we've also got Jay here in the background. So today we're going to be talking about diabetic eye disease, which is sort of like a term that encompasses two major sort of clinical entities or manifestations, that being diabetic retinopathy as well as diabetic macular edema. And before we get into our discussion on these two topics, I just want to also let our listeners know that there are whole other ways that diabetes can affect the eye. So it's also important to consider these other things like glaucoma, cataracts, microvascular nerve palsies. And for the purposes of today, we won't be covering those, but it's just important to know that that does happen. So I reckon we begin our discussion today, boys, on diabetic retinopathy. Jason, let's kick us off with a definition. What is diabetic retinopathy?
Cool. Well, how I would think of it is it's a microvascular complication of diabetes. So you've got micro and macrovascular complications. And it's secondary to, I guess, prolonged high blood sugar, which causes vascular damage, particularly in the retina, and so you get symptoms like chronic vision loss.
Yeah, well, I mean, that's exactly, you've hit the nail on the head, right? I guess a more formal, succinct definition of that would just be it's chronic progressive retinal manifestation of hypoglycemic vascular damage. So fellas, how prevalent do we think diabetic retinopathy is? Anyone have any guesses?
There's 8 billion people on Earth at the moment. So how many people have diabetes? Maybe 2.5 billion. It's a random guess. So like 250 million. I reckon 10% of people with diabetes have retinopathy.
Okay, fair enough.
How far off am I?
Not that far off, to be honest, actually. So there was a study published back in 2021 by the American Academy of Ophthalmology. They said that about 20 or about 22%, I think, of the global diabetic population had diabetic retinopathy. So it's about 103 million people. So a little bit less than what you estimated.
Still pretty high.
But it's still pretty high, right? So it's important that we're talking about it today. And then I guess closer to home as well, the National Eye Health Survey, which was published back in 2016. So it found that diabetic retinopathy is a leading cause of blindness and visual impairment here in Australia, particularly in our First Nations population. So it's actually a really big problem. So Joe, do you want to talk to us about the pathogenesis of diabetic retinopathy?
Yeah. So this is first principles medicine, so understanding the pathophysiology will help you understand the condition itself. So it's initiated and driven by the damaging effects of chronic hypoglycemia. So you have chronic elevated blood sugars that can damage the retinal vasculature. So these damaging effects lead to structural changes, which culminate in increased permeability, reduced blood flow. So with that increased permeability and reduced blood flow comes retinal ischemia. And we know that the body responds to ischemia with upregulation of vascular endothelial growth factor, or VEGF, right? And neovascularization.
So, I mean, that sounds like a good thing, Joe. Why are we worried?
What do you mean it sounds like a good thing?
Well, you've got ischemia, and then you get new blood vessels,
Yes.
so it supplies more oxygen.
Right.
Why are we worried?
Okay, yeah, so it does sound like a good thing. The body's releasing VEGF in response to this ischemia, but these blood vessels that grow are actually structurally abnormal, so they're not proper blood vessels. And so they're more prone to leakiness that then serves as a prerequisite for some of the complications of diabetic retinopathy, such as vitreous hemorrhage and retinal detachment.
Right.
But good
No
question.
worries.
Fascinating.
Okay, cool. So now that we've discussed the pathophysiology a little bit, I reckon we switch gears and we start thinking about some important, maybe like learning principles that are useful in medical school with regards to diabetic retinopathy. And there's a couple that I think we're pretty keen to chat about today. So Jason, do you want to take us through what I think is our first learning point for diabetic retinopathy?
Sure. So we talked about how I think 20%, 25% of people with diabetes have retinopathy. So clearly not everyone develops it. So in terms of screening for it, it's important to be aware of risk factors that make people more likely to develop it. So obviously the main one is poor glycemic control, and that's obviously a very important factor. I'm sure we've all seen people in the hospital with like a 10% HbA1c.
Yeah.
We know normal, is 6.5. Other than poor glycemic control, the duration of diabetes is very important. The longer vessels are exposed to high blood sugar, the greater the risk, right? Other things, so poor general vascular health, things like smoking, high blood pressure, high cholesterol, dyslipidemia, and like a personal history of cardiovascular disease, stroke, any sort of vasculopathic changes. And interestingly, there's some studies that have shown a higher risk during pregnancy.
Oh yeah.
I'll throw that over to one of you guys. Any ideas why that might be?
Joe, you take this one. I've got no clue.
The human placental lactogen.
Damn, he's on the ball. So yeah, it is. The placenta makes a lot of different hormones. One of them is human placental lactogen, which actually counters the effects. Shit. What is it?
You don't even know.
No, I literally knew it a couple hours ago. It makes...
insulin. Insulin resistant, surely.
Yeah, insulin resistance. That's the phrase I was going
There we go. Bit of obs and gynae in our opthal episode.
So what did you just say? You said, is it human placental lactogen? Cool. So yeah, you're really on the ball, Joe. Yes. It is in fact human placental lactogen, which is a hormone produced by the placenta, and it acts in the mum to increase insulin resistance, and also as a growth hormone. So yeah, it can increase the risk of retinopathy and increase progression. 2 for 1, bit of obs and gynae in our opthal episode. Yeah.
In the baby or the mom?
In the mum. If the baby had retinopathy, that would be...
It'd be unfortunate.
Diabetic retinopathy, that would be pretty bad, yeah.
Fair enough. Okay, so thanks for that, Jason. I reckon I'll take our next sort of learning point, if you guys are okay with that. And I think the next thing to discuss would be the classification of diabetic retinopathy, because it's super important, but it's also really well described and an easy question for us to ace in our exams.
And it will come up.
It definitely will come up. I've been asked in clinic about this as well. So worthwhile knowing. So broadly speaking, diabetic retinopathy can be classified into 2 sort of sub-entities, either non-proliferative or proliferative disease. And that's on the presence or absence of neovascularization, or those new blood vessels that you were talking about, Joe, at the back of the eye. So non-proliferative diabetic retinopathy is no neovascularization, and then proliferative diabetic retinopathy is the presence of neovascularization. And so for non-proliferative disease, you can further substratify that or subclassify that into mild, moderate or severe, depending on the specific structural changes that you see at the back of the eye. So when you have a look into the retina and you have a look at the blood vessels and for any other changes, you can see these changes that we were talking about. So for anyone who's listening, if you want to maybe hit pause on us and quickly go on Google and type in diabetic retinopathy fundus photo and have that open while we're discussing this, I think that'll be a really useful thing. Because
not if you're driving.
Yeah, not if you're driving. Because otherwise I'm just waffling on about retinal vascular changes and you don't know what's going on. So fellas,
Yeah.
give me some changes, or list some changes that we might see at the back of the eye.
So I know for severe non-proliferative diabetic retinopathy, you get microaneurysms, venous beading, and ERMA.
Yeah. Do you know what ERMA is?
Jason, do you know what ERMA is?
Intraretinal.
It's a microangiopathy.
Microvascular abnormalities or anomalies.
Okay,
Right.
there we go.
Well, we got it in the end as a team.
And what does that mean?
So ERMA is basically when there's like shunt vessels within the retina, and they're a sign of severe disease. Yep. It's really hard to see that on fundoscopy as a medical student.
It's hard to see everything on fundoscopy as a medical
That's
student.
true. That's true. That's very much ophthalmology territory. But some of the other changes that we're talking about, so the microaneurysms, they're tiny sort of vessel outpouchings. I think you mentioned, Joe. They're quite easy to see. They just look like tiny little red dots. Some other changes that we can see at the back of the eye? Anyone?
Hemorrhages.
Yep, hemorrhaging. Do you know the specific type of hemorrhaging you might see?
Big ones and small ones. So dot and blot hemorrhages.
Yeah, dot and blot hemorrhaging, exactly. So because we have diffuse sort of capillary leakage, we get blood moving out of the vessels, and dot and blot hemorrhages literally just look like tiny little red dots and blots at the back of the eye, and they're quite characteristic for diabetic retinopathy. Anything else?
Guess you've already said, but in severe, maybe neovascularization, so growth of new blood vessels around the optic disc.
Yeah, so for proliferative disease, if you've got neovascularization, that's that. And like you said, yeah, they're easiest to see around the optic disc margin. They kind of look like tiny little vessels. Sometimes they're a bit hard to see, but tiny little red hairs almost. Most prominent at the optic disc margin, like you said, Joe. But that's proliferative disease. So if we circle back to non-proliferative disease, aside from the microaneurysms, you mentioned venous beading as well, Joe, didn't you?
I did, yeah.
Yeah, so venous beading is when you get sort of circumscribed dilatation of the retinal veins, so then the veins end up looking quite tortuous, almost like a string.
Like a sausage on string.
Oh, you took the words right out of my mouth.
Is that right?
String of sausages, technically, was
There
the
you
right way
go.
to say it.
That's
But-
what
Sausage on a string.
yeah, and I guess anything else. There's another two changes that are really characteristic.
So you've got your hard and your soft exudates, right?
Yeah. Do you know the difference between the two?
So I know that hard exudates
Yeah.
from leakage of lipids and proteins
Yeah.
from your permeable vessels.
Yeah. And what does it look like?
So they're well circumscribed.
Yeah, yeah.
And they're like yellow, tan, white color.
Yeah, it depends on the photo, but yeah, they're definitely more yellow than the soft wool spots.
Yeah. And then your soft exudates are actually not exudates at all.
No, they're not.
And they are just areas of like the actual retinal nerve tissue.
Yep.
Infarction.
Yeah, essentially.
Yeah.
And they just kind of look like whitish lesions. So they're more white than the hard exudates, and they're less well demarcated. So the edges are a bit blurry.
Yeah.
And that's the sort of key difference between the two when you're having a look at the back of the eye. So for non-proliferative disease, we can grade it mild, moderate, severe, like I said, based on the presence of all these changes that we see. So for mild disease, that's diagnosed when there's microaneurysms only. So you have a look at the back of the eye, you can only see microaneurysms. Moderate non-proliferative disease is you have a look at the back of the eye and you can see microaneurysms as well as other things. So the dot and blot hemorrhaging, the hard exudates, the soft exudates, etc. And then severe non-proliferative disease is a bit more of a formal definition, but for our purposes, as long as you see retinal hemorrhages and microaneurysms throughout the retina, venous beading in half the retina, and those ermas, which we probably won't see, but the ophthalmologist will see, in a quarter of the retina, that's severe non-proliferative disease.
So just to clarify, it's or for all of those, right?
Oh, yeah,
so
not and. Yeah, or, yeah.
Yeah, you either see those hemorrhages and those aneurysms
Yeah.
everywhere, or you see the venous beading in half, or you see the erma in
Yeah.
a quadrant.
That's
and
a
counts.
that's a good catch, yeah.
I have a question,
Sure, go for it.
Maria.
Me, go.
We talked about those microaneurysms and the dot and blot hemorrhages.
Yep.
They all seem like red dots to me.
Yes.
Can you tell the difference between hemorrhages and microaneurysms? Is it just like microaneurysms are right next to the vessel or something?
Yeah, it's a great question. If we had an ophthalmologist here, you'd probably get a better answer. But, so microaneurysms are smaller than dot and blot hemorrhages, that's for sure. And yeah, they would definitely be along the vessels because they're outpouching of the vessels.
Yeah.
But dot and blot hemorrhages usually occur because of rupture of the microaneurysm anyways. So I'm not sure if we can technically use the location per se. I mean, someone can fact check me on that. If one of the listeners maybe wants to fact check and send in a feedback, they can.
Comment an angry 1-star review correcting Maria.
But yeah, I think the biggest thing for me, at least in my understanding of it, would be that microaneurysms are a lot smaller than the dot and blot hemorrhages.
Yeah.
But they're still red dots, right, at the back of the eye.
Jason,
Makes sense.
for severe non-proliferative diabetic retinopathy,
Yeah.
do you know about the 4-2-1 rule?
Yes, that's what we just described, right?
So can you explain it?
Yeah, of course I can. So 4 quadrants of microaneurysms.
How many?
4.
No, how many in each quadrant?
Oh, right. You have to have at least 20 microaneurysms in each quadrant. So that's a
Yeah.
total of 80
That's 80.
microaneurysms.
That's a lot.
Yeah, that's a lot. But I mean, blood vessels are small. And then 2 quadrants of venous beading and 1 quadrant of erma.
Great.
Yeah.
Okay, no worries.
Cheers, Joe.
It's very,
You will.
very specialist stuff, but I guess for the gunners listening,
Jason's a gunner.
Jason.
We're all gunners here.
Well, the gunner's talking, yeah.
fair enough. Joe, do you
Yeah.
want to take us through our sort of next important learning point?
I do,
for
okay.
today?
Yeah.
You do, yeah.
So third learning point. So the classical presentation of someone with diabetic retinopathy is a chronic progressive vision loss. But actually, most patients with diabetic retinopathy are going to be asymptomatic. So despite all the structural and functional changes that are occurring within the eyes, most patients don't actually notice the visual symptoms until the very late stage. Yeah. And so with diabetic retinopathy, patients experience a gradual generalized decrease in vision. And because of this, they typically don't present to healthcare settings until they develop a complication that dramatically reduces their vision, such as vitreous hemorrhage or retinal detachment.
Okay.
Yeah. An important caveat to this, however, is that patients may report visual symptoms earlier if they develop diabetic macular edema, which we're going to talk about later, and that can occur in any stage of diabetic eye disease. So for this reason, it's important that patients with diabetes, especially poorly managed diabetes, have regular optometry checkups.
Yeah, that's a huge practice point for our patients with diabetes, or our future patients with diabetes. So I think we've covered all that quite nicely, fellas, unless there's anything we want to add to that. I think we switch gears now and have a bit of a chat about our approach or clinical evaluation of a patient with diabetic retinopathy or a patient with suspected diabetic retinopathy. And I think it's high yield or really useful to frame it in the sort of concept of an OSCE station, maybe.
I'm already sweating.
Yeah, I know. PTSD from last year's OSCE. I don't know how we made it this far, but here we are. So for our listeners who really absolutely just want to know the bare minimum to pass an OSCE station, this is it. So just pay attention, right? So let's imagine it's the day of the OSCE and we're at the door of the opthal station. So we're right there, trigger's in front of us, whistle's gone off, we turn around. We've read the trigger, and based on the trigger, we suspect that there's going to be a patient in the room with diabetic retinopathy, or it's at the very least one of our top differentials. So let's talk about how we would approach this. Jason, do you want to take us through the kind of history we might think about obtaining once we enter the room in this particular scenario?
Sure. Let's throw it back to our first principles. So we know the normal anatomy of the retina. That's beyond the scope of this talk. We know the pathophys, right?
We do. We just went over it, yep.
Yeah. So we know how that translates to our clinical presentation. Joe took us through that. Chronic progressive vision loss. So you want to take a history presenting complaint and you want to target it towards those symptoms, right? So first thing we should do is start with, clarifying exactly what's wrong with their vision. Is it just general vision loss? Is it peripheral? Is it central? Is there blurriness? Is there associated double vision or diplopia?
Yeah.
Are there flashes and floaters? Is it both eyes? Because we'd expect diabetes, systemic disease, you'd see it in both eyes.
Yeah.
Or is it just one? When did it start? And has it come on rapidly or slowly? This should be, as we said, like a chronic gradual onset.
Yeah.
Has it gotten better and come back in episodes? That doesn't really fit with diabetic retinopathy. And any other associated symptoms. So obviously your systemic things like fever, weight loss, but headache, nausea and vomiting, and many more I'm sure you can think of. And then you want to ask questions about the patient's diabetes.
Yeah. Super important, yeah.
Yeah, and we talked about how there's certain risk factors for developing retinopathy when you have diabetes.
Yeah.
So we're going to target our questions towards that.
Yeah.
So you want to know what type of diabetes they have, type 1 or type 2. That's just generally important. You want to know how long they've had it. That, as we discussed, is a risk factor. You want to know about their management of their diabetes. So how good is their glycemic control? And there's a few ways you can ask about that. You can ask, do they measure their blood sugar? Do they prick their fingers? And what's the general range? You can ask if they know their last HbA1c. You want to know how they manage it. So is it diet controlled, which would be pretty good? Are they on, oral hypoglycemic agents? Are they on insulin? And something you can ask to look pretty slick is the 3 Ps of hypoglycemia. So hyper, yeah. So patients are chronically running high. They might have, on questioning, polyphagia, polydipsia, and polyuria. And then also you want to know about other complications of diabetes, other microvascular ones, so that's nephropathy and peripheral neuropathy. You want to know macrovascular, so that's neurological, heart, and peripheral arterial disease.
Yeah, cool. That's a pretty comprehensive history of the presentation.
Oh, and one thing I'll add on, you also want to ask... Wasn't that comprehensive? You'll also want to know, do they see a podiatrist regularly? Do they see an optometrist regularly?
Yeah, okay, cool.
Why is that important?
I hope the audience could hear Jay. He asked why that's important. It's important because the optometrist regularly screens their eyes, so you would know if these new visual symptoms have developed since they last saw the optometrist. It might be new, that sort of thing.
Okay.
Yeah, and in terms of seeing a podiatrist, that's really important because diabetic patients get a lot of complications with their feet, ulcers, peripheral neuropathy, Charcot's foot, Joe, what is Shalko's foot?
No, it's not going. We're not doing that.
All right. Moving swiftly onwards.
Yeah, so I think that is really comprehensive as an approach to sort of the history of a patient with suspected diabetic retinopathy. I think a really smart or slick thing to do as well when you're taking an opthal history is to take a previous ophthalmic history. So the way that I kind of approach it is I'll take a history of the presenting complaint, do like a little systems review, then do a prior ophthalmic history before moving on to my comprehensive history.
Well, nobody's perfect, Maria.
Well, no, but we can all try to be, Jason. And so my prior ophthalmic history or review would involve me asking things like, does the patient wear glasses or contact lenses? Have they ever had any trauma to the eye, right? Because if someone's had, or trauma to any of the eyes, if someone's had trauma to their left eye and they can't see out of it and now they're coming in with right-sided visual complaints, that's important, right? Because you want to preserve the vision in that right eye. Have they had any previous surgeries or lasers to the eye? Did they have to wear a patch over their eye as a kid, obviously screening for amblyopia? Do they use any eye drops? Stuff like that, so you can kind of get a better understanding of the person and their eye. And you just sound really slick, I think.
And you should do that for all ophthalmic presentations, right?
Yeah, that like a previous ophthalmic history, because that's the organ of interest, right? After that, I would move on and do my comprehensive history, but it's an OSCE and we have a limited amount of time, so it's a targeted comprehensive history, right? So just switching back to you, Jason, because you did such a good job before.
Thank you.
What would your targeted comprehensive history look like for our OSCE station?
So more about the risk factors. So do they smoke? Do they have high blood pressure? Dyslipidemia. And social history is also obviously really important. Do they drive? Because when you eventually, measure their visual acuity and all of that, you might have to have a conversation about their driving.
I think that can sometimes be a foul criteria if someone's not gotten
Those
or meets
dreaded words.
the driving visual requirements and you don't counsel them on that potentially.
Cool.
So the next logical thing we do in our OSCE is move on to examination. Joe, do you want to take us through how you would approach the examination in an ophthal OSCE?
Okay. Well, like any examination, straight off the bat, general observations and vitals. We want to start with that.
Yeah, that's
Next, move on to a general inspection of the eye. So have a look at the eye up close. Those common things.
Don't get too close, but have a look at the eye.
Yeah, okay, fine. Next thing we want to do is, Jason mentioned before, but visual acuity, right? So to do this, you do best corrected visual acuity with a pinhole. Mm-hmm. Let's talk through, we'll do a general opthal exam and maybe we'll just point out some of the findings that you might expect if someone's got diabetic retinopathy.
Yeah.
So if we're doing a visual acuity, Mia, what might we expect to find in someone with diabetic retinopathy?
Yeah, I would be expecting to see somebody with bilaterally decreased VA, like we said before. And in the history, it'd be chronic and insidious in onset, but when I test their visual acuity, I'm going to expect bilateral reductions in their VA.
Yeah, so VA being, visual acuity, so you're doing a Snellen chart test.
Yep. And then, with the pinhole as well, provided there's nothing else going on with the eye, I wouldn't expect a drastic improvement on vision with pinhole for diabetic retinopathy.
So no improvement in pinhole meaning?
So when you pop the little holes in front of the eye...
Yeah, we all know how you do it, but no refractive error, right?
Yeah, so not a refractive error. Yeah. So it's involving probably the retina and not the lens.
Yeah, I know, but you can still have things at the back of the eye that improve with pinhole, right?
Okay.
Yeah, you can just...
I'll take your word for it.
Take me,
as the episode queen.
Take my word for it.
Okay, so moving on. Next, you perform a slit lamp examination, right? So Jason, if we're doing a slit lamp exam on a patient, what are some things we might expect to find with diabetic retinopathy?
I think it's generally pretty normal. There are some changes. So obviously we mentioned diabetes is also independently a risk factor for cataracts. So you might see a cataract. And then I know in later stages, I can't say the Latin term for it, but you can get neovascularization of the iris itself.
So you want to help him out?
Yeah, iritis, I say iris, but iritis rubiosus.
Pretty good.
That's the term, yeah.
Write that down. So some of the late stage complications can include cataracts as well. That's important with the visual acuity, is that you might actually have a refractive error and think it's cataracts, but it's underlying or masking a diabetic retinopathy.
Yeah.
Yeah?
Okay, so don't stop at the front.
Keep going.
Keep going to the back.
Okay, so you look at the front of the eye and then you want to do a comprehensive posterior examination, right? So the steps involved can be remembered with a acronym or initialism? What are we? It's an acronym.
It's
right?
an acronym.
Yes.
An initialism, you would say it each letter.
I say AFROC.
It's not AFROC. It's AFROC.
But we'll go AFROC for now. Okay, so AFROC, Jason.
Yeah.
off the top of your head, can you remember what so Afro C is the approach for a posterior eye exam, right?
Yeah.
What are you assessing there?
It's burnt into my brain, Joe, so of course I can remember it. A is acuity, which we've done.
We've done that, yep.
F is fields, visual fields.
Yep.
R is reflexes, pupillary reflexes,
Yep, so reflexes, that's right. So you got direct, consensual, accommodative, and RAPD, so the relative afferent pupillary defect. Yep, keep going.
O is ophthalmoscopy, which is fundoscopy.
Yeah, so that's probably the most pertinent test for diabetic retinopathy. So you got a fundoscope, getting up nice and close, and you're looking at the fundus of the retina for the changes such as microaneurysms, venous beading, exudates, etc.
And should we just say, in an OSCE, they're going to give you like a fake eyeball, not a real patient. So feel free to get...
actually, no, you can get a real patient.
Oh, that's terrifying.
Hess, yeah. So the lecturer that...
Dr. Hessen.
Well, I mean, it's Professor Hessen Razavi, really.
Okay.
He does a lot of the ophthalm teaching at the University of Western Australia, which is the medical school that we all attend. And he was a fake patient once in an OSCE station, and he dilated one of his eyes, and the students had to look into his eye.
Does he have diabetic retinopathy?
I would say no.
All right, so moving on. So we've done Afro. What's C?
C is colour vision.
Yes. Okay. All right, and then there's some other non-ophthalmic examinations you might do just to be more comprehensive. So if you're in an OSCE and you're maybe saying, to be, for a fully comprehensive examination, I'd also like to do cardiovascular examination, a peripheral vascular examination, or a diabetic foot examination. Yeah, but you're probably not going to have time to do all those things. And that wraps up exams, Mia. Back to you.
Back to me? Okay. Well, I'm just going to pinball back to Jason. Jason... In this scenario, what investigations might you consider ordering?
So we can think of bedside bloods imaging.
Yep.
In terms of bedside, there's no real bedside investigations unless you count like a slit lamp.
We wouldn't, no.
No, we wouldn't.
I wouldn't.
Joe doesn't.
Very controversial topic.
Well, it's not really bedside, right? Because if you're up on the ward and you need to see opthal, they take you down to the clinic.
Moving on to bloods. You want to get basically like your metabolic syndrome bloods.
Yep.
So HbA1c, lipids, UECs. You can get a urine ACR, especially because in diabetes patients will often get albuminuria, and like LFTs for a metabolic associated fatty liver disease. I think that's what we're calling that now. It's changed acronyms like 4 times.
Yeah, I think MAFLD.
MAFLD.
Not NAFLD.
Okay.
For anyone listening, metabolic associated or non-alcoholic fatty liver disease. Okay, so I think that covers, unless anyone has anything else to add, our approach to the patient.
Sounds good.
Yeah, I think we've done all right. But just to summarize that, because that was a lot, in terms of the approach and the sort of archetypal presentation of a patient with diabetic retinopathy, the things that you're looking out for in the exam or in real life are a middle-aged, vasculopathic patient with poorly controlled diabetes. You're looking for gradual, progressive bilateral decline in vision. The most important exam you're going to need to do is fundoscopy, or having a look at the back of the eye to look for those structural changes that are consistent with diabetic retinopathy, that being the microaneurysms, dot and blot hemorrhages, hard exudates, cotton wool spots, venous beading, and the intraretinal microvascular abnormalities. So I guess all that's left for our topic, or our discussion of this topic, diabetic retinopathy, is to touch on management. The management of diabetic retinopathy is in part governed by the type of retinopathy the patient has, right? So it kind of varies a little bit dependent on whether there's proliferation or not. So Jason, do you know anything, or do you want to talk to at least?
Do I know anything?
Anything about non-proliferative diabetic?
I'm a little bit wounded.
Sorry.
But so...
Talk to the management of non-proliferative diabetic retinopathy.
Sure. So in non-proliferative diabetic retinopathy, there's no real specific management from the eye perspective, but generally you want to do all of your good diabetes management. So in terms of non-pharmacological things, that's optimizing their diet, their exercise, smoking cessation. That's real important. If in an OSCE it's mentioned that they're a smoker, you have to flag that as an issue. Weight loss. You want to manage their other comorbidities, so lipids, blood pressure, and achieve good glycemic control.
Yeah.
You need to send them for ongoing ophthalmic review. So you've now diagnosed, we know they have this condition, they need to be seeing an ophthalmologist.
Yeah.
If they don't have retinopathy and they just have diabetes, the general screening recommendations is 2 yearly by an optometrist or an ophthalmologist.
Yep.
If they have diabetes, but they're particularly high risk for any of the risk factors we mentioned, or they're indigenous, they require annual screening.
So I've got another question. All right, so someone takes all that advice. They get their sugars in control, lipids in control, they stop smoking, stop drinking, they do everything right. Yeah?
Yeah.
Can they reverse the effects of their non-proliferative diabetic retinopathy?
Do you want to take it? Do you want me to take it?
It's my
Am I
understanding.
the only one that doesn't know?
Sorry, you're the only
No,
one.
we know. Jeez, you're the only one that doesn't know.
It's my understanding that the vast majority of the changes you can't reverse.
Yeah.
You can only slow progression
Yeah.
or stop. Yeah.
Okay.
And that's why it's so important for screening, right? And to recognize risk factors in addition to just having diabetes, because you can't actually reverse the changes. So the whole point of management is to halt or at least slow down progression. So making sure we recognize diabetic patients, and particularly the ones that are at risk, sending them for either 2 yearly or annual screening. That's the sort of premise behind that, is if we can get on it early, stop it from progressing, we can save or preserve sight.
Got it.
A lot of doom and gloom here.
Well, I mean, it's your vision, Jason.
True.
So that's the management of non-proliferative diabetic retinopathy there. And those points are also relevant for proliferative disease as well. You're not going to counsel a patient with proliferative disease to not induce those sort of lifestyle changes. But for patients with neovascularization, because there is that neovascularization, there are some specific treatments that ophthalmologists can use to target that. So Joe,
Yes.
do you know any treatments
I do.
specifically?
I know.
You do?
I know two.
You know too. Talk
Yeah.
us through them.
Well, I know first line is laser
Yep.
photocoagulation
Yep.
and our anti-VEGF treatments as well.
Okay, all right. Do you want to talk us through, or does anyone want to talk us through retinal laser?
Yeah, I will.
Okay, go for it.
Okay, so they use a laser and they burn the ischemic sort of peripheral retina, and this both decreases the amount of VEGF that's released, and it induces regression of the neovascularization.
Yeah, exactly.
Right. So does that come with a cost to vision, like in peripheral vision?
So, in theory, yes, but in reality, no. So, our central vision is coordinated or controlled by a very small part of the retina called the macula, and the periphery, like obviously it exists and we can see our periphery, but it's with really low visual acuity.
So our eyes are like our brains. We only use 10%.
Well, seemingly, if that's true, then seemingly so.
That's a myth, by the way. I don't want to
Is
put
that
that
a
out into the medical,
universe,
yeah,
medical
literature.
field. But yeah, so any sort of minor changes to the peripheral vision, you don't actually consciously
Right.
appreciate, and it doesn't affect your functional vision. So
Cool.
so your functional vision is still the same.
Yeah.
And then that other treatment is anti-VEGF. So it's an intravitreal injection, so meaning injected into the eyeball.
Yep.
It has to be done by a specialist, is my understanding.
Yeah, I wouldn't want a non-ophthalmologist
No.
injecting my eye.
And they inject antibodies with VEGF. So they go and mop up the molecules, and that sort of induces regression of the abnormal blood vessels.
Oh, and just to add, actually, I think it's important to note that often a combination of laser, I don't know what your experience was in clinic, boys, but for me, a combination... Okay, fair enough.
We
Where were
won't
you?
touch on that.
Okay,
But
fair
anyway.
enough. But yeah, a combination of laser and injections are commonly used. So the sort of textbook answer is first line treatment is laser. So pan-retinal photocoagulation is the formal name for it. But often in reality, a combination of the two treatments are used to get good control of the proliferative disease and best preserve sight.
And the patients should still be trying to control all those risk factors,
Yeah, 100%.
like we spoke on for non-proliferative, just because they're getting the laser treatment and stuff like that. Doesn't mean
Yeah,
they-
100%. Okay, I think that sums up our discussion on
Yeah,
diabetic
frankly, I'm
retinopathy.
sick of it.
Fair enough. Anyone have anything they want to add?
No.
No. Okay. Fair enough. Do we want to do a bit of a pimp question insert here?
Shall
Do
we?
we want to have a bit of a break? Should we have a bit of a 5-second break for our listeners and talk about any interesting cases?
They don't need a break. They can pause the podcast.
Fair enough. We need a break.
I'm-
Now let's talk about interesting...
Unpause the podcast and continue listening. All right,
Make
I've
us
got an
away,
interesting
Joe.
case from the week.
Do you actually?
Yes,
Go. Okay,
I do.
go for it.
I'm not an opthal, but it's an opthal case.
All right, fair
well,
enough.
Oh.
I'm on oncology. It was
Right.
a hem-onc patient, came in, Hodgkin's lymphoma, and immunosuppressed.
Reed Sternberg cells.
No. Immunosuppressed and had a vesicular rash on their face that had spread down to their nose. Jason, what is the name of the eponymous sign that I'm looking for?
Well, everyone knows that, Joe. The one sign is
Pausing
Hutchinson.
while he Googles.
I'm just... Can you guys hear me typing? Hutchinson sign.
Correct. What does that mean?
So you're describing shingles, right?
Yes. Shingles being...
Shingles being a reactivation of varicella zoster virus.
Yep.
Yeah. And so Hutchinson sign indicates that it's involving the nasociliary nerve, which is a branch of the ophthalmic nerve, and therefore you're worried about it involving the retina or the eye.
Very good. Yep. That sounds like a lot of information, but that is a classic PM question. Hutchinson sign and nasociliary nerve. Yeah, nice, Jason. Well done.
Thank you.
Mia, very silent over there.
I mean, just for context for our listeners, Jason is the king of all these signs.
Of eponymous names.
Of eponymous names, that is.
You should have thrown the question to me. I wouldn't have got it.
I'm the king of pimping people on eponymous names and then forgetting them myself and having to Google
You are going to be
give
the worst
answer.
consultant one day. Like, genuinely, everyone's going to be scared of you.
Scary person.
I'm not a scary person.
No, until you start whipping out all these signs to the poor second years.
Should we talk a little bit about some diabetic macular edema?
I think that's fair.
Yeah,
That's
let's
a fair
do that.
shout.
A bit
Alright.
of dessert.
Fair enough. So we mentioned earlier we're going to cover diabetic macular edema. It's one of the clinical entities or manifestations of the sort of umbrella term diabetic eye disease. Jason, you did a fantastic job of describing diabetic retinopathy earlier. So do you want to tell our listeners what diabetic macular edema, or DMO for short, is?
Sure. Well, I hope I live up to my previous example. So you have diabetes.
Yep.
It involves the macula,
Yep.
which is the central part of the retina. When you're looking straight ahead, that's what's getting most of the light.
Yep, vision, yep.
And it also has most of the cones in your eye, so most
Okay.
responsible for colour vision.
Sure. Okay. Yep.
And there's edema, so fluid in the macula, presumably from the permeability of the blood vessels.
In the macula? On the macula? Where is it?
Within the region of the macula.
Yeah.
Jason, sorry, you got that right. So I guess more formally, it's retinal thickening and edema of the macula, which is caused by diffuse capillary and microaneurysm leakage in the area. So it's similar sort of pathogenesis and pathophysiology to diabetic retinopathy, but just with a focus of the macula.
Yeah.
I think it's useful, again, to frame our discussion around some key learning points. So Joe, do you want to talk us through our first important learning point?
Okay, so I guess one important principle for DMO is that even though it's very similar to diabetic retinopathy, same risk factors, same sort of archetype of patient, it's a separate entity. So in your mind, picture them as two sort of individual manifestations of diabetic eye disease being the overarching thing. Because even though they're linked through etiology and pathophys, there are several key differences in the presentation and the management of these conditions. And importantly, DMO can develop at any stage of diabetic retinopathy. So even patients with mild, non-proliferative diabetic retinopathy can develop DMO.
Yeah. Yeah, and that was really useful, I found, in my learning when Prof. Razavi just came right out and said, just think of them as two separate things. So then I think a second important learning point, because the macula is involved, like Jason mentioned earlier, vision will be affected. So because the part of the retina that's responsible for high acuity central colour vision is where the problem is, patients will notice a change in their vision, usually a lot earlier on. And I guess the specific visual complaints that you should be on the lookout for a patient when you suspect DMO, or really any pathology affecting the macula really, would be things like blurred central vision, because obviously the macula controls central vision. There's another key sort of finding or complaint that patients with DMO or even things like age-related macular degeneration might complain of. It's got a fancy name. Do either of you guys know what I'm alluding to here?
Yeah, metamorphopsia.
Oh, Jason, you always know it. So metamorphopsia is like a fancy way of saying things that are supposed to be straight look wavy. So patients aren't going to come in and say that, obviously. They'll come in and say, oh God, doc, like I'm looking at the door frame, I'm looking at the door and the edge of the door frame looks wavy.
But even then, they probably won't, right? You have to elicit that. You have to ask.
Well, in the OSCE, yeah.
In the OSCE, yeah,
OSCE,
sure.
yeah. In real life, though, they'll come in and say, oh, I'm looking out the window and the window frame is wavy.
Yeah.
Like things that I know are straight look wavy. And that's really sort of sensitive for macular pathology.
And
yeah.
Joe, how would you test for that objectively?
Objectively,
Well, I guess you can't. It's a philosophical question.
are you looking for an Amsler grid?
I am looking for an Amsler grid, yeah. So, yeah, look that up.
Look that up. I mean, for anyone who doesn't want to look it up, an Amsler grid is basically just really in a nutshell. So it's a grid with lines and a black dot in the center, and you instruct the patient to look centrally at the black dot. And then you say, whilst you're looking at the black dot, also appreciate the lines. They're not supposed to look directly at them. Do any of them look wavy? And if they say yes, then that's positive for metamorphopsia.
Cool.
Okay, Jason, do you want to talk us through...
But does that mean they have DMO? Or are
It
there any other
doesn't-
conditions they might?
Yeah, so an Amsler grid is used largely in clinical practice for patients to self-monitor age-related macular degeneration at
Yeah.
home. So it's not specific for DMO, but it's still sensitive for any sort of pathology that affects the macula.
Right, cool.
But yeah, Jason, do you want to talk us through our third and final key learning principle for DMO?
Sure. We mentioned for retinopathy, first line classically is photocoagulation. In DMO, first line is anti-VEGF.
Yeah.
So obviously you do all the other stuff, so systemic control of diabetes, management of comorbidities, lifestyle changes. However, for vision-reducing DMO, first line is intravitreal anti-VEGF. If it doesn't respond to anti-VEGF, we call it refractory DMO. And the other options from then, intravitreal corticosteroids and laser photocoagulation. Importantly, with photocoagulation,
Retinal laser.
first of all, you need to be able to say it. Second of all, you don't laser the macula itself because that would be too damaging to vision. They laser like the retinal tissue around the macula.
Okay. Do we have anything else that we want to add to that?
Well, we could ask the listeners some questions.
We could ask the listeners some questions.
Yeah.
We could do that.
Yeah.
All right, so I've got some for you guys listening along, if you're still listening. And Jason and me might
Haven't crashed your car looking up a fundus curve.
All right. Okay, first question.
Yeah.
What are some of the ophthalmic complications of diabetes?
Let's give a pause so our listeners have a chance to think about it.
That's probably long enough. All right, let's go with Jason.
Yeah, so we've mentioned retinopathy, we've mentioned DMO, some other things, cataracts,
Yep.
glaucoma, and cranial nerve palsies.
Great, okay. All right, what are the changes seen on fundoscopy that are consistent with diabetic retinopathy?
Okay, I'll take this one. So the characteristic changes that you'll see at the back of the eye when you have a look for diabetic retinopathy are microaneurysms. Oh God, even I've forgotten now.
Stalling for time. Dot and blot hemorrhages.
Dot and blot hemorrhages, venous beading, hard exudates, cotton wool spots or soft exudates, intraretinal microvascular abnormalities, or as well as neovascularization. Don't forget the neovascularization.
Yeah, neovascularization is important, and some late stage findings as well. They could have plus or minus.
Late stage findings, so you mean complications?
Yeah.
So like a vitreous hemorrhage,
Yeah.
Retinal
detachment,
Right.
stuff like that, yeah.
Great, good work, guys. All right, last one then. So in terms of the ophthalmic exam, what is OSCE and its components?
All right, visual acuity, visual fields, pupillary reflexes, ophthalmoscopy, and color vision. And I'm a bit sick of Joe asking all the questions. So let's say the year's 2040.
Okay.
You're seeing a patient in clinic. They have health, illness, anxiety disorder, and they've been worried about COVID ever since it plagued the world.
2020.
Is it a
Yeah.
new
20
one?
years prior.
COVID?
No, yeah, it's been mutating. It's pretty dangerous.
Okay.
So back to square one, basically.
The world is out of ivermectin, but this patient has stockpiled high-dose hydroxychloroquine, and they've been administering it
Yeah.
for the last 20 years.
As you do.
What are you worried about in terms of ophthalmic complications?
Joe, you take this. I know this one. You take it.
You know it?
I know it. You go.
So there's no ivermectin.
Yeah.
Is it worms?
Honestly, good answer, and we'll pay it. But what I was looking for was bullseye maculopathy, seen with hydroxychloroquine long-term use. And realistically, you might see that in patients with like rheumatoid arthritis or SLE.
Thank you.
Yeah, that's valid. Yeah.
You're welcome.
Is that
Fair
high
enough.
yield?
That's super low yield.
But it does come up in one of the lectures, I think. So, I mean, if you're a gunner.
Jason has been pushing the
You can
envelope of
honestly
medical
just-
school to find the lowest yield facts ever learned.
Yeah. When you're crushed every day on the wards, it makes you feel bigger, you know?
Sure.
Welcome to Last Principles Medicine.
Yeah.
Okay.
Maria, do you want to give us some take-home messages?
Yeah, I'm going to wrap it up there. Okay, so I think the most important take-home messages from today would be to understand that diabetic retinopathy represents microvascular and organ damage to the eye that occurs because of diabetes. It's a clinical diagnosis which you can make when you have a patient that has diabetes, as well as the characteristic fundoscopy changes that we've really harped on about for the past sort of half an hour. The mainstay of management of diabetic retinopathy is improved glycemic control. However, for patients with proliferative disease, there are specific management options, including retinal laser, as well as anti-VEGF intravitreal injections. And then I think for DMO, the most important thing as a medical student is just to know that it's diffuse capillary and microaneurysm leakage in the macula, which commonly produces noticeable visual symptoms, and it can occur at any point. It doesn't have to be at end stages.
Cool. So always be on the lookout.
That's a good take-home message.
Nice.
Nice.
Oh, yeah.
All right, thank you guys.
Thank you.
I think that wraps us up for today. Thanks, Joe and Jason, for coming on
all right.
and having a chat with me about diabetic eye disease. Be sure to check us out on Spotify, the 1pm podcast. There's a whole bunch of other episodes on also equally interesting topics. We've got some Notion notes on our website. They're super handy.
1pm.wiki. is that-
1pm.wiki. Yep. Thanks, Jason. Give us a like, give us a rate, give us your honest comments. We're here. We're ready for them.
Unfiltered. And if anyone's looking to sponsor us, we will take anything. We will take anyone. We have zero standards. That's a joke.
You've been on one episode.
But yeah, thanks for listening. We hope you found this enjoyable and informative. And yeah, be sure to come back and check us out again.
Thank you so much for listening. We're really excited to be collaborating with Becky from Becky's Notes, a UK-based resource to produce an infographic for our visual learners out there. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. These visually striking notes are a refreshing change from all these boring textbooks out there. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.